And now I have the pleasure of introducing Dr. Sarita Mohanty. And Sarita is, I'm very, very lucky to have wonderful people like this in my life as well, like Roland and Sarita. And so Sarita actually, reading her, I try to read her resume to my kids every night before they go to bed. Like, just do this. Like, she went to Berkeley undergrad and Boston University Medical School and Harvard for her residency and Harvard for her MPH and UCLA for her MBA. And she's worked at some of the best institutions in the country, and usually they recruited her to be amazing. We were very lucky to have her in our firm for a time where she really helped us transition and learn about population health and work with some of our clients as they were making those early transitions. She now is a leader at Kaiser in Northern California, and she'll talk to you about some of that. But Sarita really is, in my mind, one of the people in the industry who is able to connect research and clinical and operations together. And I think that's why Kaiser has asked her to solve their Medicaid challenge. So Sarita, it's all yours.
Thank you. So first of all, I want to thank Alan for, and Esther and Dr. Torrance for giving me this opportunity to be here tonight. It's always exciting to talk about work that I am so passionate for and about. It's been, it's really been a trajectory or course, I guess, I don't know, it's been pretty circuitous in some ways, my career path. I started, I'm an internal medicine physician, and but I've always really been passionate for the safety net. It started when I was doing my medical school at Boston University, at Boston Medical Center. Even when I was at the Beth Israel Deaconess, I worked in community clinics doing primary care, had a chance to do health services research at Cambridge Health Alliance, where I saw a huge number of uninsured and Medicaid members coming in. And then, from there, I went down this path of, I went into research, as, Alan talked about. I got this MPH, and I was going to be a health services researcher trying to solve the problems for the safety net. But then I said, well, no, I really like to implement. I like to operate. I want to go out. And then I joined Alan's team and got this wonderful opportunity to get to work with delivery systems, with the safety net, and try to redesign healthcare. And examples being specialty care. We had some real great work that we were able to accomplish around the specialty care front and access for low-income individuals. Then I moved into the health plan setting, and that was a real, I think, eye-opener for me. It really gave me the opportunity to really understand the payer-provider models and all of the things Alan described in detail. It was really important for me to understand conceptually, how to, what is the right model for healthcare? And I was working at LA Care, a Medicaid health plan. We were doing a lot of really interesting things for the population. We had a number of provider networks. One of the real challenges we faced as a health plan was that coordination of care. Because we had so many different providers, so many different hospitals, we didn't have one common platform for health information exchange. And the providers had those same struggles as well. So how do you manage a population? And especially those that are underserved. And so when I went to Kaiser, and I'm in Northern California, I was challenged with this opportunity to say, Kaiser is growing, they're predominantly commercial, but they are also growing in the Medicaid market. And in fact, Northern California is currently at around 260,000 Medicaid lives. Southern California is even higher. We're actually at California-wide close to 600,000 Medicaid lives. And the real question was, wait a second, so why are they using the emergency department so much? And what about all this disproportionate psychiatric care that they need? And is our model going to fit and help support all the needs of this population? And wait a second, actually, we have commercial members who also have similar struggles, because if you remember, people are going into the exchange, and then maybe their income goes down, and they go into Medi-Cal, and then they go back into the commercial, they get a job. So these are the kind of things. So I was asked to come up and say, let's work with our medical centers, with our primary care providers, and really try to understand how we can make the model a little different, and so I'll talk a little bit. I think I put these slides here just to give context about Kaiser. We do serve 7 regions within 8 states. We have 10.2 million members, 18,000 physicians, and 180,000 employees, 38 hospitals with a lot of co-located medical offices. And we have other 622 medical offices and other outpatient facilities. Just to give you context about the size, And, and we've had 70 years of providing care. So you look at the market or the membership dynamic or demographic, and you can see that majority are employer groups, but this Medicaid and CHIP product is growing. We're about 8% throughout all the regions in Kaiser. And it's actually really challenged us because Kaiser has this, for those who are Kaiser members or are familiar with Kaiser, has this one-stop shop, integrated healthcare. It has the EHR that talks to the patient, talks to all the different providers. But when we talk about care teams, so Kaiser has a care team. Primary care, specialty care, care coordinators in the system, social workers. But what about that behavioral health specialist that's taking care of the member in the community? What about that community agency that's been providing services? What about those community agencies that are helping them with food insecurity and transportation and community-based adult services? That was the piece that Kaiser was a little unfamiliar with. It's working outside of the four walls of Kaiser Permanente. So, so this is, again, the one-stop shop. We have all these great services, but what do we do beyond that? What do we have to do to really help our patients and really partner with the other individuals who touch these members and influence their care? So, I always want to remind people, and people have probably seen this slide and recall from the McGinnis work in health affairs, that medical care is just one component. When we're looking at healthcare delivery, we really have to look at other factors, the environmental and social factors, the personal behaviors. How often do we ask our patients, our members, about what they want or why they do things? I have patients who, and I see patients in Kaiser, and they come in and you look at their chart, and I have this access to their chart, and I can see, oh, they got 6 ED visits in the past 6 months. Why are you going to the ED? So you start to ask them, and they said, well, I don't have transportation. I have 2 jobs. I don't have childcare. It's just easier for me to go to your emergency department than come and get an appointment. But they're not getting their preventative care. They're not getting, so these are the kind of things. So what are the things we can do to help and support those? So I wanted to just talk a little bit about some of the things we're trying to do in Kaiser, and we're starting with our Medicaid population because there is a disproportionate non-medical social need component that we see just by virtue that they're low income, and also concomitant behavioral health issues are prevalent in this population. So we have come up with a goal in partnership with communities to really identify and address the individual's most pressing basic human needs as a standard and integral part of quality health care. So this is, and it's interesting because when you talk about it, you talk to the physicians, they're like, oh yeah, no, we get this, but how do we do it? This is really the question. Like, what do I need to do as a physician? I am so busy. Who's going to support me in getting this accomplished? So some of the initiatives that we're working on, and we're still learning as we go. So we're trying to think outside the box and look at best practices across the nation. Medicaid plans that have done this really well, and say, what can we do? We're trying to understand and document the social needs at a patient and population level. What's that social needs assessment look like? What questions do we need to ask? How do we incorporate those into a predictive modeling tool that helps us understand who's really high risk? I mean, if you look at medical conditions and you put it in a model, you could say, okay, the top 1%, they're high risk because they have these 5 or 6 chronic conditions. But what if their main issue is food insecurity? That really should put them in that higher bracket of that they need some care coordination or a social worker to help come to their home. So these are the kind of things. Navigation is really critical, and we're trying to navigate patients to community resources and partnering. And Kaiser has been really good about saying, well, we can build it. We can build it. But we also realize that the community has a lot to offer. So there are opportunities to partner with them rather than saying Kaiser is going to internalize all the services that could support the social non-medical needs of a member. So we've proactive outreach and engagement. With our Medicaid population, we are doing calls to every member And we're actually so it's new member onboarding. We're triaging them and trying to figure out what level of care they fit into and whether they need a social worker first, or they need a nurse, or a combination. Do they need a pharmacist that needs to come to the home? Those are the kind of things we're working on. And then care coordination and high-risk case management. We're looking at not only the population of Medicaid as a whole, but also like high-risk perinatal, because there's a higher proportion of perinatal, pregnant women and NICU babies that we see in the Medicaid population. And we're also looking at subset populations within Medicaid, like the seniors and persons with disabilities. So those are kind of things that we're trying to really uncover and understand. And we're looking at how we can leverage technology. We're having to, I am charged with making sure that we collect the data and measure the metrics. And what's your return on investment? You do all these initiatives, but what does this mean? We have the triple aim, quality, member satisfaction, but what about the affordability? Because we get less than one third of the revenue in Medicaid than we do for commercial. So but we have the same system of care that we provide to members regardless of their payer status in Kaiser Permanente. So what do we need to do? So really that value case is critical. And we're collecting and tracking necessary data elements. We're looking at what kind of incentives we need to give to providers. And we're also looking at where the care is provided. Again, being able to ascertain, can we do things in the home? Telephone, we can be on telephone, video visits, texting, those type of things. And so a lot of that is in the works. So I just wanted to give you a flavor, and I'm really excited about actually speaking to all of you about and hearing your questions, and also to the panelists. So I look forward to it, and I think my time is up, so I will stop, and thank you very much for your time.